fast sometimes. I think your brain's
Okay.
going faster than ours. That's the problem.
Sure, I'll try to be a bit slow. Thank you for that. I feel like a 50-year-old guy coming with chest pain. Obviously, the first thing that comes to my mind would be coronary artery disease, especially in somebody who has risk factors. It looks like he has hypertension, and he's on like at least 3 or 4 medications for that. And
Yes.
out of them, only losartan seems like a first line. Losartan and the thiazide are first line medications. So usually, if someone is on more than 3 drugs for controlling hypertension, that means they have what we call as resistant hypertension. So I'd be curious to know what's causing that and whether that was something which was diagnosed from before or whether it actually worsened recently. Because a recent worsening would make you think of anything that causes secondary hypertension, like
Right.
maybe renovascular hypertension or something like that.
So that's the first part of the case. The first part of the case is how do you work up resistant hypertension? And so that's the first thing we want to go over. And then we'll give you an answer. The chest pains ends up not being important here. What ends up being important is controlling his hypertension, because everything gets better as we start to get his hypertension under control. So let's think about resistant hypertension, the differential in a 52-year-old man who's had hypertension for a long time. And Sherry, since you're putting all this in the chat, why don't you say it? You have to unmute yourself, but that it's so. I want you to justify each of those things.
Those are just from a mnemonic that I previously studied. But for hypercalcemia, I think it leads to vasoconstriction, and that's why like calcium channel blocker is a medication for hypertension. And hyperthyroidism, I think that will lead to maybe high output cardio state that can lead to increased systolic blood pressure, and hyperaldo that increases retention of salt that leads to hypertension.
So I think, and we'll have to ask Brooks if this is right, I think we now just call it aldosteronism and not hyperaldosteronism. That's probably a picky point. Is that right, Brooks?
I think that's fair.
Okay.
I think that's fair. Yep.
But Aldo, we will get back to Aldo in a second. Okay. Keep going. You're doing great.
And for renal artery stenosis, the kidneys are underperfused, so that can lead to activation of the RAS system. And for fibromuscular dysplasia, I think it's similar mechanism.
Right. So which would be more likely in this man?
Since he's older, I will say, and it's a male, I will say renal artery stenosis.
Right. So when you say renal artery stenosis, you're implying atherosclerosis, because my understanding is fibromuscular dysplasia does show up just like renal artery stenosis. It's just not. It's more of a spasm than a blockage.
And Cushing, that's just high amounts of cortisol, and I think it is also due to salt retention. I'm not actually sure. I forgot.
Okay. So Alexander raises a very interesting question. This has been around for 30 years. So I guess you're thinking that this could be an unusual case of fibromuscular dysplasia. When faced with a guy like this, and we took the tack, it turned out that his chest pain was really hypertension related. His hypertension was out of control. We controlled his hypertension a little bit better. Chest pain went away. We worked him up. He didn't have any significant coronary artery disease. What should we work up? Well, let's come up with a test list, Sankalp. now that Sherry has given us this list, which the only thing it left out is coarctation, which would be very unusual in a 52-year-old. And when he first showed up, we might look for coarc. But what things might you do? I can tell you he was not hypercalcemic. His calcium had been perfectly normal, and his TSH was normal.
Okay.
And those aren't things that I usually think of, and unless there's well, we get the calcium anyway. So what would be your workup, Sandkalp?
So of course, like we can start with the CBC and BMP, but in terms of specific causes, we can get plasma renin levels to look for primary hyperaldosteronism. We could also get serum cortisol, the AM cortisol levels, as well, to see if like he has that elevated, and that could be a potential Cushing's case. For rest of the stuff, for renal artery stenosis, usually CT scan, CT angiography is the diagnostic test of choice, but I would rule out other causes before trying to rule renal artery stenosis out.
Okay.
Yeah.
So does the BMP change your desire to work him up for aldosteronism?
Yes, definitely. If his potassium is not low, if it's normal or high, it definitely goes against hyperaldosteronism as a cause. So definitely that'll change my
Good.
further
You're
work.
about to learn something, because I think you're actually wrong. That was feedback, by the way. He did happen to be hypokalemic. He had potassium in the high 2s and had that over and over again. So let's let Brooks talk a little bit about working up. Who should we work up for aldosteronism?
Yeah. So what's a couple of interesting things. There's been a lot of attention lately to how poorly we do screening these patients, and the classic definition of someone with hyperaldosteronism is someone with severe resistant hypertension and hypokalemia, and we now know that is a specific example, high specificity if you're looking for those people, but terrible sensitivity, and that the significant majority of these patients actually will not have hypokalemia. So we're under screening, and currently there's pretty good recommendation. In fact, one recent study suggested, this was done at Stanford, that at that institution they had only screened 2% of the patients that would meet current criteria for hyperaldosteronism. So it's a good institution, and rates there were poor for screening. So people you should think about screening: anybody with 3 blood pressures 150 over 100 on 3 different days. So that's a lot of people. Anybody with 3 medications that's still not controlled, or anybody controlled on 4 medications, also going to be real common. Anybody with hypertension and sleep apnea, and then anybody who's got hypertension and then potassium drop on a diuretic. So those patients who start diuretics and they drop, that's not normal, it's not typical. And so those patients, that's almost a spontaneous hypokalemia equivalent if you're seeing that on a diuretic. So that should get you interested. And then family history of early onset hypertension, and then anyone with a first degree relative of a known patient with primary aldosteronism. And then anybody with hypertension and an adrenal adenoma. So that's a lot of patients.
Right. And for those of you who listen to Annals on Call, I've had a couple of episodes on aldosteronism. As Brooks just said, it's way underdiagnosed. It's way underdiagnosed. Now, in this case, we did send off the tests. Sandkalp, what test do you want to send out?
The plasma renin levels.
And?
About the morning cortisol levels, the ATM cortisol.
Okay. Sherry, do you agree with him?
You said the aldosterone and the morning cortisol level.
He said renin.
Renin, and aldosterone.
Yeah.
So it should be renin and aldosterone. Yeah, we can go ahead and get a cortisol, but that's not working them up for aldo. And we did get a cortisol, which was okay. So this is actually a really challenging thing, and I believe, and Brooks, you can help us here, that how to interpret the renin and aldo is an evolving situation. So we're taught to look at the ratio, but I've had people tell me that what we really need to look at, if the renin is suppressed and there's some aldo, as long as the renin is suppressed, then you can start to believe that maybe that they are making too much aldo.
Yeah, so I think in general, we have a history of overthinking screening for hyperaldosteronism. And so in an ideal scenario, you would probably do this test in the morning, but that's not practical. So I suggest you just do it whenever it occurs to you that you should do it. And then the list of medications that we may have all been taught in the past that should be stopped has really dwindled, and a lot of folks would advocate that there are no medications and that completely render these labs uninterpretable. And I'll give you the two specific examples that come up most often are ACE inhibitors, which may raise renin, but I'll tell you that anybody with hyperaldosteronism is going to have a suppressed renin even if they're on an ACE inhibitor. And the other one that causes some pause is mineralocorticoid agonists. So like, for example, spironolactone, a lot of folks will hesitate. You can still screen a patient on spironolactone. What it will do is raise aldosterone, but if, again, as Dr. Centaur mentioned, if that renin is suppressed, that's very eye-catching. That actually means you haven't blocked the mineralocorticoid receptors, and there's still excess mineralocorticoid floating around that's suppressing renin. So we generally think if you're going to screen, you can screen anybody on any drug right now. And I agree that the suppressed renin is more eye-catching than what the absolute aldosterone value is.
And our patient did on multiple occasions have suppressed renin. He also, I believe, did have an elevated aldo at the same time. So his ratio was actually high. And we got all that back and then sent him to endocrine clinic. But there's a really interesting thing that's going on in the aldo field that's really important for all of us to remember. And this is something that I totally did not know for 40 years. I've just really learned this in the last couple of years. I always thought of aldosteronism as an adenoma, and you find the adenoma and then you try to retrieve the adenoma. But what I'm reading and what has been on a couple of the podcasts that I did is there are islands of cells that make aldo in the adrenal gland that are not an adenoma, but you can still be making too much aldo without an adenoma, which means that the only way to treat those people is biochemically with medications, as opposed to the adenomas, which you can actually remove. So just because you don't find an adenoma doesn't mean you don't have aldosteronism. Did I get that right, Brooks?
Yes, and I'll be glad to. So that's a newer concept in terms of the anatomy that we're seeing in adrenal glands in patients with bilateral adrenal hyperplasia, or idiopathic aldosteronism is one phrase used to describe this process of bilateral secretion of aldosterone. So the classic Conn syndrome with unilateral adenoma is a percentage of these patients, but a large chunk of them are going to have this bilateral process. And so now we moved towards a concept. When we start this imaging, you're really not looking necessarily for an adenoma. You're doing what we're calling a subtyping of the patient to see if they're unilateral versus bilateral, and that process has a couple of steps. And I'll stop here because I'm sure there may be more to talk about in that vein.
Okay, so let's just go back over what we started with. Travis, you had volunteered to help, so did this fit your understanding and what you're teaching to your students? And do you have any questions? And so here's an opportunity to ask questions of Brooks.
Yeah, I mean, I think, starting off with this patient, you know, I think the biggest challenge is knowing kind of when to pull the trigger, in ordering some of these tests, because, as you know, hypertension is so common. In a 52-year-old, it's very common, and kind of the keys and kind of low hanging fruit to look for. I think that's the important thing to take, from this, having someone coming to your office for the first time, they're 52 with hypertension. A good question is like, hey, how long have you had hypertension for? Because I don't think that's something that I ask a lot. I mean, I don't know if it's something that you ask a lot, but I just, was really thinking, hey, that's a really important question. If they've had it for so long, maybe they don't share that with clinicians. Rafa mentioned some other points about, if the patient is obese, do they have sleep apnea? There's a lot of secondary causes that you can kind of weed out and look at. But really, like, who are the people that we need to be screening and sending, to, one, endocrinology, doing some imaging to looking for adenomas, or even, Conn syndrome, hyperaldosteronism. And, I think a lot of these medications work differently on different patients. So, starting them on ACE inhibitors, calcium channel blockers, when's the right time to add hydralazine or clonidine? Probably later, but also, the other diuretics like chlorthalidone, and when to add those. So I think there's a lot of things that are awesome with this case, because I think it brings up a lot of the good points on, hey, when do I refer this person, and, what are the good questions to ask?
Yeah, this guy was easier than most because he'd had it for so long. He had high blood pressure despite 3 drugs, and he was hypokalemic. So that's the easy case. And what Brooks said, I think, is really, really important. And when I've discussed this with a couple of people on the podcast, and they really do make the point that we're and Brooks made this point about the study from Stanford. We're really under testing for aldosteronism. Now, there was a great question in the chat, Brooks, and I want you to address this. And some people say, I don't need to screen for aldosteronism. I'm just going to put them on spironolactone. And there are really good data that the 4th drug should always be spironolactone. So as an endocrinologist, how do you think about that, Brooks?
Yeah, so it's we love endocrinologists. I love to be organized, and sort of when you're doing a test, say, why am I doing it? So I will take you through what I would say is the first 3 steps, and then why we're doing the imaging. So first step is screening. And the big message again is we tend to overthink that, overanalyze what drugs are on. Just do it. Just get the aldosterone-renin ratio. And I'll wait, we may come to this later, but what the cutoff of an abnormal screen is being debated. But classically right now, 20 to 30 in the typical units in the US lab. Now that's going to be different than a lot of overseas labs, but 20 to 30 is an aldosterone ratio is suspicious. We then like to confirm this with a confirmatory test. The most common one being a outpatient salt-loaded 24-hour urine sodium and aldosterone collection. And that's considered confirming aldosteronism. And then the third step is imaging. And the important thing there to remember is, why do we do that? Is because a small percentage of patients with aldosteronism, not all of them, a very small percentage may have a malignancy. So an aldosterone secreting adrenal carcinoma, rare, but you wouldn't want to miss that. And then another percentage that's not insubstantial, 20–30%, are going to have a unilateral adenoma where you have a chance to remove that and completely change the course of their disease, potentially. So that you wouldn't want to miss either. The big problem being that the adenomas don't lateralize reliably on your scan. So then we need to think about ABS, which I can talk about later, because that's where this gets complex.
Okay, so this guy ends up being fairly complex for a lot of different reasons. So let's go back over on the wards. We ordered the Renin-Aldo, documented that he had aldosteronism, and then we sent him to endocrine clinic. And so while most of us would refer this to an endocrinologist to work up, why don't we understand what the endocrinologist is going to do, because we might be able to anticipate some of those things. So why don't you take us again through that very carefully, Brooks? And you've seen the chart. So the first thing we did is we did the screen, and we sent it to endocrine. And what did they do then?
So I happened to look, his aldo-renin ratio when you guys screened him was about 50, so fairly compelling. And he had a great history that was consistent with aldosteronism. So in the endocrine clinic, I happened not to see him, but they did a nice job. They elected to do the most common confirmatory test, and there are a list of these. Saline infusion is one of them, but the one that's done the most commonly outpatient is a 24-hour urine sodium and aldosterone after a salt load. And one way in Alabama, we don't have to do a lot of coaching typically to get salt levels up sufficiently. What you're looking for is 200 sodium level of 200 on the 24-hour urine, and usually our diet is plenty to do that. But you can actually do that with 4 packets of bouillon is a recommended way if you're concerned the patient won't consume enough salt. You can also do it with salt tablets, but they're less palatable. So you have them ingest this salt for about 3 days, and then at the 3rd day, they complete a 24-hour urine. And you do want to make sure the potassium is normal during this test, because a low potassium can suppress aldosterone. So that's the one thing you need to make sure of. And again, you don't necessarily have to stop a lot of drugs for this portion, this confirmatory portion of the test. We in this patient proceeded with the drugs he was on.
So,
and he ended up, go ahead.
Brooks, Sean Carter asks a good question.
Mm-hmm.
Are you ever so convinced by the ratio that you go straight to imaging?
Yes, and actually it's not a ratio by itself, but if a patient has spontaneous low potassium, totally suppressed renin, and then aldosterone over 20. So basically an infinite ratio. So renin of 0, aldosterone over 20, spontaneous low potassium, you're done. We don't do any further confirmatory testing. In fact, those folks, we would go ahead and do a CT scan.
Okay. So they did the confirmatory test in right. Our patient, although they might not have needed to. And I guess if you're in a place where it's not easy, it was easier for us. We're discharging him from the hospital, and we have an endocrine clinic right there. This is at our VA. And so the best way to make sure he had follow-up of his aldo was to send him to endocrine clinic. If I were in private practice, or I was a hospitalist in a private hospital, and I had a good colleague who was a general internist, I wouldn't necessarily send this patient to an endocrinologist at this point, I don't think.
Agreed.
Is that crazy, Brooks?
No, and I think if we start screening who we're supposed to, you won't be able to get these people into endocrine because of the volume of patients you're going to be turning up. So we would want, we would hope that the screening and confirmatory testing for sure could be done by a general internist, and probably go ahead and do the imaging. And then at the point of making decisions about adrenal vein sampling, that's probably where we should get involved. And I do think the can of worms this is going to open sort of globally, if we really start screening like we should, is the fact that AVS, adrenal vein sampling, is difficult. There are not a lot of centers with a lot of experience. And that's going to be the rate limiting step for some people, is access to good adrenal vein sampling. And that'll come up a little bit later in this case.
Okay, so if we're taking care of the patient by ourselves, we did the right thing in terms of getting the ratio. The ratio was pretty darn high. So we could have gone straight to CT of the abdomen.
You could have, especially with spontaneous hypokalemia.
Right, and he did have spontaneous hypokalemia despite being on potassium-sparing agents. And so he did get a CT of the abdomen and had a small right adrenal adenoma.
Yeah, and I'm going to answer, this is a perfect time to answer a couple of questions in the chat. So this needs to be an adrenal, so CT abdomen by adrenal protocol. And what you want is pre and post contrast washout. But really, there's a couple of questions that are a little, that are directed at different questions. So one reason we do adrenal CTs is to rule out malignancy, and that's where the Hounsfield units come into play. So I see a question in there about Hounsfield units. Most aldosterone secreting adrenal adenomas are going to appear perfectly benign on CT. They're going to be low Hounsfield, fatty lipomas. So that's more of a cancer related question and not a functionally related question. The other question I see, what's the 24-hour urine sodium for? So basically what you're doing is just pumping these people full of sodium. So if you have a normal aldosterone renin axis, if you're full of sodium, your kidneys are going to sense that high volume, and they're going to lower renin, and therefore aldosterone will lower right along with it. So you're just demonstrating that even despite a very high load of volume and a suppressed renin, the aldosterone continues to be inappropriately secreted.
Okay, so now we have an adenoma. There are two different things. Let's talk about treatment for a second, because he was sort of complicated in treatment. And I didn't realize this till I was reviewing the chart again. He'd been put on spironolactone. What dose do you use of spironolactone? And this guy, we'll talk about this guy in just a second, but what doses do you use of spironolactone for this problem?
So most people would say start at 12.5 milligrams, which is a whiff. That is almost never going to be your effective long-term dose, but that's a starting dose. And what we see a lot in hypertension and endocrine disorders is we get the drug started and then nobody follows through to titrate it up. So you're almost wasting your time if you don't. It's kind of like insulin. If you start it, that's great, but titrating it up is really where the value is. And so you're going to need to typically go up to potentially 100 milligrams a day, but you're going to do that in a stepwise fashion. But starting at 12.5 or as much as 25 is reasonable.
Right. So I assume this is different in like our patient who had significant hypokalemia would probably need more spironolactone than someone who has a normal potassium, but you screen them because they have resistant hypertension. And so you do get suppressed renin, but do you run into the hyperkalemia problem with spironolactone in those patients, or is it the same that you still have to go pretty strong to control the blood pressure?
I think it depends on their degree of aldosterone oversecretion in terms of how high you're going to go. We don't see hyperkalemia terribly often in these patients because their tendency is the opposite, but certainly I would monitor them. Generally, if they have good renal function, that's less likely than if they have renal insufficiency. So I'd watch for it, but would not have high anxiety about hyperkalemia.
Now, this guy, just to talk about treatment for a second, Sandkalp, why did he want to get off the spironolactone? Why would someone complain about spironolactone?
So like gynecomastia is a common complication.
Yeah, and he apparently did have gynecomastia. So what are you going to do now, Sandkalp?
So we can give eplerenone, like that's a good alternative which doesn't cause gynecomastia.
Right. So, and that's what they actually did for this patient. He's currently on eplerenone. Brooks, have you had much experience with needing to switch to plerinone?
Yeah, so the estimates are 50% of people who take spironolactone and men will get gynecomastia. So it is extremely common. Sometimes folks aren't bothered by it. Sometimes folks are extremely bothered by it. And this patient definitely was and brought it up at the first visit to the endocrine clinic. So plerinone can be used. It doesn't have activity so two issues with spironolactone. It's got activity, so it's an antagonist of testosterone, and it also has activity at the progesterone receptor, so it can cause spotting in women who've got a uterus. So it's got issues with cross-reactivity at other receptors. The plerinone is more of a selective mineralocorticoid antagonist. It's not as potent though, so the doses of a plerinone are basically double. So you start at 25 instead of 12.5, and then Dr. Centaur happened to peek at this guy's chart today, and he's still only on 25 of the plerinone. So this is a perfect example of we've started the drug, but we have not titrated it up. Almost certainly he needs to go up on that to get in a way to check and see if you're actually treating these people sufficiently. One is to look at their blood pressure, but also if you do a sufficient job blocking the mineralocorticoid receptor, you should start to see the renin come up. So you can actually check the renin and make sure it's no longer suppressed. That's actually a useful way to see if you're getting good activity of these drugs.
So I think that's, that's a specific problem here, Brooks, and I'm so glad you brought it up, because there's so many drugs that we forget to titrate. And that's what you're telling us, is that if you're dealing with resistant hypertension secondary to too much aldo, that if we're not working on maximizing the dose of that drug, we're sort of wasting time and money.
Mm-hmm.
And that happens. That happens with a lot of medications, and that's one of the problems that we have. So this is going to be a philosophical, political statement. One of the problems with our healthcare system, I'm a happy academic hospitalist, but we've really lost something by not having the same person discharged from the hospital and see them back in the clinic, understanding that this needs to occur. And that message gets lost in the handoff from the inpatient to the outpatient way too often. So that's my political statement for the day. And it's not just this. Okay, so he also had an adenoma, and this guy has really bad hypertension. So what are we going to do about that adenoma? Because you just told us, Brooks, that you'd like to take it out, because if you take it out, we might just fix him.
I'd like to take it out if it's the right thing to do. So that's where this gets fun. So right. He had an adenoma that localized to he had a right-sided, approximately 1 centimeter adrenal adenoma with Hounsfield units that were -5. So it's a fatty adenoma.
Okay.
I'm looking at the chat too. What do folks want to do at this point?
So now you got an adenoma, people. Call your endocrinologist and say, what do we do now? Okay, teach them, Brooks.
Well, so who wants to take it out? The adenoma is a trap. All right, that's right. So there's debate about what to do about this. So if a patient's very young, below age 35, there's some data suggests that you could just move forward with resection. The odds of an incidental adrenal adenoma at that age are so small that there's almost certainly a relationship, and there's data that supports that. But once you cross age 35, the problem is adenomas become very common. My number I like to remember is about 7% at age 70. So that's a lot of potential incidental adrenal adenomas. So there's no way to be sure that this adenoma is actually the source of the aldosterone. And in fact, the source of aldosterone it lateralizes to the contralateral side in about 50% of adenomas in adult patients over age 35. So that, again, the reason for the CT was not necessarily to find this adenoma, it was to rule out a malignancy and to see if we even have a chance at a unilateral resection. But you can't hang your hat on a unilateral adenoma. You've got to proceed with ABS.
So how do you decide to go through the trouble of lateralizing, and why don't you explain to us what they actually did, because we do have numbers of them
Yes.
lateralizing this, and
Yes.
why is that useful, and if we're going to be screening all these people, do we need to lateralize everybody? What would be your indication to lateralize?
So the first thing to do is have an individualized discussion with the patient and look at their history. Ask yourself and the patient the question, would you have surgery under any circumstances? If the answer is no, then you should treat them medically, which is what you would do if this was bilateral anyway. We don't do bilateral adrenalectomy for hyperaldosteronism. We just think the price is too high in terms of adrenal insufficiency. So if you know you're not going to move to surgery, there's no point in pursuing ABS. But if the patient is healthy enough or willing to consider an adrenalectomy, unilateral adrenalectomy, then you would like to have that information. And the problem is that this is an area of very narrow expertise. I'm going to quote you a couple of things I found about this that are interesting. So one group of interventional radiologists self-published their data on ABS, and they estimated that you had to do 36 of these to become competent and 27 a year to maintain competence, meaning that you were cannulizing both adrenal veins at a 94% accuracy rate. So that's a ton. That's 2 a month ABS, according to this group, to maintain a sufficient level of expertise. And almost very few centers do that. So this tends to go to very specialized centers that do a high volume of ABS. So if you're in a place where this is the only ABS they've done that year, this radiologist said that in his first year, he self-published, he got in both veins 50% of the time. So you may as well flip a coin. So that's where I think this is going to get difficult as we screen more, is that folks who don't have good access to this really are faced with a dilemma because they're not going to have access to really accurate ABS. But this patient, and this patient is an illustration, I think we have a wonderful health system where this patient was seen, but it's not a high volume ABS center. So this patient went for ABS, and there are a multitude of protocols, so I could spend an hour on that and I won't, but there are a variety of ways it can be done. You can cannulate the left and right adrenal veins simultaneously. You can do them one after the other. You can do it with ACTH stimulation. You can do it as a bolus. You can do it as an infusion. So there are a variety of protocols and no one consensus on what's best. This patient had ABS that was done without cosentropin and what's called sequential cannulation, where they cannulated left and right, or vice versa, it doesn't matter. They did one at a time. And this person's aldosterone in the left adrenal vein was 760, whereas on the right it was 24. And then I'll be glad to answer this if people want to, but we normalize that for cortisol values and do a ratio. And bottom line, this person's aldosterone strongly lateralized to the left, which is the opposite side of where his adenoma was. In addition to that, though, it looks like there's a chance they didn't get in on the left. That was the interpretation of the doctor seeing him. Although when I did my ratios today, I think they did probably get in on the left. So I think it was actually a valid study lateralizing. They thought they didn't get on the right. So I think this study lateralized to the left, but our docs weren't confident, nor were the surgeons. So they basically told the patient it was an equivocal study, which happens a lot.
So now we have this clinical problem, which any of us could run into, and that is trying to get his blood pressure under control. He is reluctant to have the surgery, and if he has the surgery, he might go outside our system to get it, is what they've written in their notes. If you, Brooks, if you were taking care of him at this point, it sounds to me like what you want to do, he's only on 25 of a eplerenone right now. So it sounds like what you would, your first pass would be to increase his eplerenone.
Yeah, and I have a quick comment on it. I suspect what happened here is that I think in his head, just reading through the chart, he expected this ABS to lateralize to the right, to the side of the adenoma. And then when he found out it lateralized to the other side, he felt unconfident in the test. And I suspect part of that is because it didn't warn it, that 50% of the time, that lateralization on the CT is inaccurate. And that it may lateralize to the other side. But regardless, I think he feels like this test wasn't good, and so he had thought about going outside to get a repeat ABS. But should he decide not to do that, yes, I would push the eplerenone now, really until the blood pressure is normal, and then I would check a renin and see if I'm actually starting to get some elevation of renin where I'm blocking those mineralocorticoid receptors.
So you would use the renin values in addition to the blood pressure to convince yourself that you're giving enough eplerenone. That's how you would titrate. Yes.
And there's a little data that outcomes are better if you unsuppress that renin.
That's really useful. That's totally new to me. Had anybody in the chat heard of that before? It makes total sense. I mean, the physiology makes all kinds of sense. So currently we're stuck with this guy, and it seems to me like there are several things you've taught us, Brooks. The first is to not get too excited about the adenoma, because there's only 50% chance that that's where the aldo's coming from. And I think this case probably reinforces one of the things that I'd mentioned before, is that most people with aldosteronism it's not coming from an adenoma, but rather it's coming from islands of cells within the adrenal gland. And the only way that you're going to be able to treat that in a guy like this is to actually do an adrenalectomy on that side. Did I get all that right, Brooks?
That's true. And another pearl, and a little bit paradoxically, is people with bilateral bilateral aldosteronism, it tends to be actually milder than folks who have a true unilateral adenoma. They have more severe disease, they have more severe hypokalemia. So you can tell a little bit from their clinical presentation what they might have.
So Brooks has done a great job. Questions in the chat. This is the 5-minute warning. So anything that we went over that you want to ask more details, because we have the man here. I think that, and I'd read up on this, and I've done a couple podcasts on this, and you've taught me a lot, Brooks, and I really appreciate it, because I think I know how to talk about it so much better and understand it. And I think what you've done is you've told us how to talk to the patients as we're going through this, because having the patients understand what's going on is really important. If we don't understand it, there's no way we can explain it to the patients. So are there any questions from the audience? So Carlos wants to know, since this guy had an adenoma on the right and he lateralized to the left, does that mean that you have to repeat the AVS, or would you have felt comfortable if you'd prepared him well to go ahead and suggest a left adrenalectomy?
Yeah, so you shouldn't, it's a great question. You shouldn't be surprised if it lateralizes to the other side. So if you've prepared yourself and the patient for that possibility, and you're confident they got in, that's the other place where I think the things got a little shaky with this patient, is there was not total confidence they had gotten in. Particularly the right adrenal vein is the one that's difficult to get into because of the anatomy. So there was concern that they may have not gotten in, but my read of it, they probably did. And so you would recommend a adrenalectomy on the other side. on the side that lateralized. And he had really strong aldosterone secretion on that one side.
So Travis has a great question. If you're not in a situation where you can get an AVS, and many of us are going to be working in hospitals where they don't do AVS regularly, as long as you're not dealing with cancer, is it ever wrong to just titrate spironolactone if they don't have side effects and a eplerenone if they do have side effects?
Yeah, never wrong. The only really consequence there is because that's what you're going to do in a lot of cases anyway if it's bilateral. But again, you're going to miss this opportunity to make a huge impact on these handful of folks who have severe unilateral aldosteronism. So one thing I would suggest is if you don't have good access to AVS, is you need to keep ordering it, because if the radiologists realize there is a demand for this, they will react typically to that. So definitely advocate if it's realistic in your institution, because I think there is going to be a lot of downstream AVS if we start screening.
Another really good question, and I think you're really convincing all of us that titration is really important in this guy for eplerenone. Is that likely to help us decrease the other drugs he's taking?
It may. I think a couple of things to remember. So even folks with a unilateral adenoma that's secreting aldosterone, once that's removed, most of them are not cured of their hypertension. A lot of them will stay on some degree of antihypertensive agents. What they are cured of, though, is the debilitating hypokalemia that can be associated with this. So you almost always cure that, and that can be life-changing for these patients. So I think you may be able to down titrate or stop an agent or two, but particularly if the duration of the hypertension has been long, you're probably not going to come way down on your blood pressure medications, but you certainly may improve things.
Great. Well, the way we usually finish this up is I get some of the people who helped us to emphasize what they think the big teaching points were. And I don't know if we discussed it, Sherry, but you need to add pheochromocytoma to your list. You still there, Sherry?
Yes, I'm here. I agree.
Okay. So what were your big lessons today, Sherry?
I have a lot of lessons, and so for the screening for aldosteronism, so first you want to get a ratio renal aldosterone, and then you confirm it with the 24-hour sodium and aldosterone, and then you do the imaging. But you can sometimes skip the confirmatory test if the ratio and the hypokalemias are very convincing. And the other thing that's pretty surprising to me is that 50% of the time, the hypersecretion of the aldosterone lateralized to the contralateral side. So just doing a venous side sampling is very important to confirm that.
Great. Sandkalp, what did you get out of this? Did I lose Sandkalp?
He's muted.
Sorry, yeah. I'm sorry, I didn't unmute myself.
Yeah, what were your big lessons?
Yeah, I think first and foremost, normal potassium shouldn't dissuade you from a diagnosis of hyperaldosteronism. This is my biggest takeaway from the start of the session. And of course, all the other points that we talked about, and especially how adenomas can be misleading, and we need to get venous sampling in the cases to figure out which side is involved, and also pearls on how to treat it and how to keep on up titrating it, and how the blood hypertension may not completely resolve even after the adenoma is actually removed. So these are really interesting things to explain to patients as well, of what to expect if they have this kind of a condition.
Travis, as an educator, what do you think are the big messages?
The big message is how much I don't know about this and how I need to befriend one of our endocrinologists who I'm pretty friendly with, but I need to start texting him more and pick his brain, because Brooks, that was just awesome. I mean, I think taking a deep dive into this really explains and breaks it down for us to, really know and not only memorize, but kind of understand the physiology behind it. So thank you.
Sal, you get the last word, since you're the you've just been sitting there quietly typing great things onto the screen, but I know that you were listening carefully and would love to hear your thoughts.
Thanks, Dr. Santor. Thanks, Dr. Ron. This is a great case. We often in clinical reasoning exercises see things that are pretty rare. And one thing I love about this case is it's going to change my practice next time I step into clinic. We have a substantial number of patients that are on 3 blood pressure medicines and poorly controlled. We ask them about alcohol, NSAIDs, and sleep apnea, but we almost surely are under screening for this. So this is going to change the way that I practice starting next week.
And that's I think there were 2 reasons that I really wanted to do this case. That's one. And the other is to try to understand, when we send to endocrinology, what they're thinking. I thought the most important thing that Brooks taught us today is there's not a dose of eplerenone. You keep increasing until you've given enough. And that, if I don't remember anything else, I think that's worth the price of admission right there. So Brooks, do you have a final thought for the group?
No, just thank you for asking me. And believe me, I learned probably just as much as you did talking through this.
Well, I think this is great. Big advertisement for next week. We're going back to liver disease next week. So we have Megan Gray coming again, and on the board will be Dr. Lindsay Shipley, who just absolutely loves liver disease also. And I'll be able to sit back and let the ladies take over, as is appropriate. Y'all have a great night. Thanks a bunch.
Thank you so much.
Brooks, you were great. Sandkalp, thanks for participating.
Yes,
Excellent
Dr. Santor,
job.
it was amazing. Yeah. Did
You
Dr.
would-
Hidebert tell you anything else?
You would think that this was a straightforward, easy problem, right? And it's really complicated.
Yeah.